about lipids, and I've got you for a couple of hours. And as someone who loves lipids, 2 hours is a long time. So I do want to make sure we've got some time for interaction, and there's Q&A throughout, opportunities to reflect, and then some time at the end if you want to come off the mic and we can have some chats. But as Monica mentioned, appointed to the Queen Elizabeth Royal Adelaide and SA. I work only in public. My clinics are around lipids and cardiometabolic risk, and very keen to support anyone who's in this space, particularly primary care. So this slide summarizes my disclosures. I think the cardiometabolic space is very interesting, and I think a clinically informed industry is important. And I very much enjoy working with these companies to bring emerging therapies to our patients. So some learning outcomes for tonight have already been published, but we want to summarize the role of absolute CV risk assessment in determining the lipid-lowering treatment regimen and goals. I want to explore the relationship between achieved LDL cholesterol and CV risk, areas that we've gone over before, and then describe indications and options for non-statin lipid-lowering therapy for patients who don't meet their LDL goals with statins alone. So I've already given that disclosure. I've got 2 full hours of lipids. There'll be a break in the middle to go to the bathroom and stand up and relax for a bit. The sequence of tonight, I've got 4 cases that I think are emblematic of some key areas for discussion. I'll go through the case and throughout have some progressive sort of reflection on questions, and then go through what I think is the correct or most correct answer. There are a couple of them that have got 2 or 3 correct answers. I'll summarize each case over a minute or 2, and then have 5 minutes of Q&A related to those specific elements of that case. And if there are clearly areas that we're going to cover in subsequent cases, I might defer those. And as I've mentioned, after 2 cases, we'll have a quick little 5-minute break, and keen to hear thoughts throughout. So I want to start with this chap. Is a 55-year-old male. He was brought in by his wife for a checkup. He has a background history of hypertension, which he himself refers to it as being lifestyle managed. He's been told historically he has borderline hypercholesterolemia, and is a reformed smoker of 20 to 30 pack year history. And he has this label of a family history of cardiac disease, and it's labeled as coronary disease. But as you know, often these family histories end up being, he's had a pacemaker put in, or he's had a valve replacement. It may not always relate to atherosclerotic cardiovascular disease. Now, he's come to your clinic and you haven't seen it for some time. In fact, he hasn't had lipids done for almost 5 years. And it's 9 a.m. and he's eaten breakfast. So what's your plan? Do you ask him to get fasting lipids and return next week? Do you take bloods while he's there? Or do you try and perform a risk assessment without them? Be a couple of ticks to have a think. So my thoughts are here that you absolutely take bloods while he's there. And I think historically, we've always focused around the purists. Let's make sure that they're non-fasting, and then to make sure that they're fasting lipids. We're comparing apples with apples each time. But the reality is that LDL cholesterol very minimally changes with a non-fasting state. The caveat to that is when patients have got elevated triglycerides, the computed formula, the Friedewald equation, breaks down, and so you will not have an LDL reported if your trigs are more than 4.5. So the bottom line here for me is that if you've got a patient in the clinic who very rarely attends, take the blood while you're there. And if the triglycerides are in the normal range, less than 4.5 as an absolute upper limit, but in general in the normal range, less than 2.5, the LDL is incredibly reliable, and you've got the information you need for risk assessment. So grab them while they're there, particularly these Australian males. So pleasingly, you were able to get his lipids done, and he returns the following day. His BMI is 32, slightly generously nourished. His BP is 150 on 90. And his LDL comes back at 3.4 millimoles per litre. His HDL is slightly lower, 0.6. Trig slightly elevated, but not terrible at 2.0. And his A1C is not normal, but is not in a diabetic range, but it's clearly got an impaired fasting glycemia or insulin resistance. Pleasingly, his eGFR has come back normal. So what's your plan here? So options A, refer to a cardiologist. B, reassure that he's probably low risk. C, start lipid-lowering therapy. He's probably high risk. D, refer for a coronary artery calcium score. We'll unpack that a bit later on today. Or E, perform absolute CV risk assessment. I'm giving a talk tonight on CV risk assessment, so I'm sure you're going to answer E. So absolute CV risk assessment. So why is absolute CV risk assessment important? Well, we understand that there is this monotonic relationship between the number of elevated risk factors and CV risk. Here you can see lifetime risk in a pooled cohort data set clearly showing that the more risk factors you have, that are uncontrolled, the more risk you have lifetime for CV events. That stands to reason. But what's really critically important is that a number of these risk factors, apart from having birthdays and bad genes, tend to be modifiable. This is nice data from Salim Yusuf, reported in a variety of different cohorts, clearly demonstrating that the attributable fraction, or the amount of risk we can explain by patients who have precocious disease, can be listed by modifiable elements. Here you can see non-HDL cholesterol, the sort of broader elements of ApoB, LDL, triglyceride-rich lipoproteins being number one attributable fraction, hypertension, cigarette smoking, abdominal obesity, diabetes. All of these elements are modifiable, at least to some degree. Poor diet, low physical activity, excess alcohol. So when we look at the attributable risk of a patient for developing atherosclerotic cardiovascular disease, these things aren't destiny. In fact, they are incredibly modifiable. So it makes sense to evaluate them, to identify them, to evaluate them, and to try and modify them in your patients. So where have we taken this in Australia? Again, this is something that you would all be familiar with, but the new Oz CVD risk calculator has come out in the last 12, 18 months, is being implemented by the Heart Foundation. It's a 5-step process. It is clearly a significant improvement over the last 10 years where we've been using American data. I'd argue there are still some gaps in it, and it's not gospel. It's guidelines and not gospel. So how do we do this? Number one is we identify individuals who are eligible for CV risk assessment. We understand that there is a paucity of data in younger patients particularly. So this really is not fit for purpose in your 30 to 45-year-olds. We understand that patients with diabetes, we can risk stratify around a 10-year earlier period. So rather than 45 to 79, we can see them slightly earlier, 35 to 79. And for First Nations people, whilst this is done on the New Zealand database, which do have Maori individuals, we have very little data to understand what the natural history of risk is in those individuals. So we tend to instead just focus on individual risk factors. So once we've identified these individuals, 45 to 79 or 35 to 79, and those with diabetes, we then use the calculator. We can put the link in the chat, but I'm sure you've seen this already. We then use a variety of variables. There are a few misses here for me. I think the total cholesterol HDL ratio is a shame. I think all of the messaging is around LDL cholesterol and non-HDL, but we still use this ratio. Most would argue that there's concordance between LDL cholesterol and the ratio, but I'd argue that it's a misrepresentation, I think, of the importance of LDL cholesterol. Pleasingly, they've included diabetes-specific elements of risk, so looking at HbA1c, time since diagnosis, urine ACR, things that we all know relate to risk in these patients. So there has been an expansion of the variables used. Important to recognize that patients with moderate to severe CKD and those with familial hypercholesterolemia should not be considered as part of this guideline or this risk calculator. They are already considered at high risk and should undergo lipid and blood pressure lowering therapies as required. Once we've put the variables into the calculator, you then identify their CV risk stratum. Slight changes in the last 10 years, going from high, intermediate, low at different percentiles, or percentages, should I say. By and large, more or less a marriage between this and what was previously recommended by the National Vascular Disease Prevention Alliance. What has been new is this introduction of reclassification factors, particularly ethnicity, calcium scoring. We'll discuss that shortly. And a stressing of communication of risk. We know that risk as a percentage is an abstract concept for patients, even for clinicians. So to try and understand risk, the diagrams that demonstrate near-peer comparisons, I think, has been an improvement. We'll go through that shortly. And then once we've identified individuals who may benefit from CV risk reduction, then implementing that. And the guidelines have felt that actually getting to the nuts and bolts in the weeds of how to lower LDL and blood pressure was outside of the scope of the guideline. It has left it feeling a little bit unfinished, that, yeah, we're asked to modify risk, but then we're not given much of a roadmap. Pleasing to know that there are hypertension guidelines coming, and there is an appetite to provide some guidance around lipid lowering that will take probably another 12, 18 months to come to fruition. But the current CVD risk calculator stops at identifying individuals and then provides some more motherhood statements around how to achieve that. So what's new? This, I think, is really nice and new, and it's been present in the US guidelines before. This idea of trying to represent the proportion of individuals with 100 dots on the page. So 23% higher is considered very high risk. But here you can see if you took 100 John Smiths, 23 of those would have an event at 5 years. That helps patients recognize this idea of near peer. And then importantly, once you then institute either lowering of LDL cholesterol or lowering of blood pressure, you can see then the impact and the number of red people that then become pink, this idea of the relative risk reduction, or absolute risk reduction, should I say. So what's different? I've mentioned already the differences between 5, 5 and 10 rather than 5 to 10, 10 to 15 and greater than 15. These new classification, this idea that we haven't included all of the variables in the calculator, but we do know that patients, for example, with South Asian ethnicity have got higher risk. We understand those who have got a family history of premature CVD, that's males under 55, females less than 65, 60, should I say. Those with CKD that aren't moderate to severe also have increased risk, but are eligible for risk calculation, but can be reclassified up. Mental illness, we know, has got a number of upstream determinants, and we know that those individuals have got higher CV risk from not only the conditions they have that may impact access to care, but also the therapies associated with it. And coronary artery calcium scoring can clearly up or down risk an individual based on their score. I've mentioned diabetes-specific guidance. It is great to see that. It's a shame that BMI isn't included in the overall calculator, but it is in the diabetes one. And then recognizing the social determinants of health, there is an attempt here to try and calculate that by CIFA quintile, CIFA being a measure of relative disadvantage, and that is done by postcode. So again, a fairly coarse assessment. We know there are good pockets in bad postcodes and vice versa, but an attempt to try and marry that in risk assessment. So let's take our chap that's come into clinic. We've put in the variables in the guideline. He's 55, male, previously smoked. His blood pressure in front of you is 150. You put in his ratio. Now, not to cheat it too much, but I often just impute an HDL of 1.0 because I really think the ratio is misleading in some respects. We'll discuss that shortly. Use of CVD medications. This gentleman's not on any. There's no history of AF. He lives in Adelaide Central. He doesn't have diabetes. So you compute out his risk. It comes out at 11%. Now we have the ability to reclassify or to upclassify him because he also has a family history of coronary disease, but he's already at high risk. This is an individual that we should consider modifying his overall cardiovascular risk. So what does that look like here? Again, 11% high risk. When you put it out on that 100-person diagram, 11 red people likely to have an event at 5 years. But what if you were to then impute improving his blood pressure? Remember, it's 150 down to 140 or thereabouts, reduce somewhere between 20 and 30% relative risk reduction from 11% down to 9%. Similarly, if you're a lower as LDL, a full 1 millimole per litre, you'd reduce it down to 8%. Now, the calculator is not clever enough to do both in those individuals, but you'd argue that the risk reduction is probably independent and additive, and so you'd expect him to get down to probably 6% absolute CV risk. So John, you've seen in clinic, he's agreeable to lipid and blood pressure modification. He's there with his wife. His LDL is 3.4, his BP is 150 on 90. So what's your first step? So option A, diet and exercise, and ideally progressing towards weight loss. So I've mentioned his BMI is 32. It's generous without being terrible. Statin, ACE inhibitor, prazosin, or fibrate. Give you a couple of seconds to have a bit of a think. The reality is that often you want to try and do multiple things at once. He's rarely in your clinic. You've got him captive at the moment. So I'd argue probably the top three are really important, and that the challenge here is to squeeze this into your 15-minute appointment, and there's probably going to be a need to try and address these one by one, but we want to try and get each of these three elements. I talk to a lot of my patients in lipid clinic about the importance of diet and exercise as critical for good cardiovascular health, particularly the prevention of diabetes, but that it is not particularly helpful to lower LDL cholesterol. That's so important because patients will often say to you, oh, but I really want to try and avoid the statin. I really want to try and avoid the tablets. And you want them to be empowered to be able to make lifestyle changes, but you need to manage expectations. And so if they start with an LDL of 3.2, achieving a 5 to 10% lowering of LDL cholesterol through great diet and exercise will only get you to the high twos. It's a long way from where we want to be. We're certainly falling a long way short of a millimole per litre reduction. So it's important to allow patients to have this opportunity, but recognize that they're going to come back, and we don't want to make them feel like they've failed. In the same way, we don't want them to make them feel like they've failed when we add an additional anti-hyperglycemic with their A1C. The same is true for cholesterol. Lifestyle is important, but very rarely gets you there. Statins, hallmark, cornerstone. We grade them by intensity. A high-intensity statin, by definition, is a statin that reduces LDL cholesterol 50% from baseline. That's a 12 of 40 to 80, Rasuva 20 to 40. There's not daylight between them in my mind. Rasuva 40, the same as a 12 or 80. clearly differences in the metabolism of these drugs where you have an interaction with one, you can certainly try the other. LFTs on one, certainly try the other. But in general, the high intensity nature of these drugs, 50% lowering from baseline. And then you have non-high intensity, so moderate and low intensity. I'd argue that really the Atorva and Rasuva family of or classes of compounds are really, you need to go no further. I do use Prava when I've got interactions with medications, particularly antiretrovirals, but in general, Atorva and Rasuva gets you most of the way. Beyond statins, and we'll unpack this with our last case, ezetimibe. This is cholesterol absorption inhibitor, and then our PCSK9 inhibitors, either through monoclonal antibodies or through small interfering RNAs. And we can achieve up to 70% reduction, more like 60% with these agents. So very potent LDL lowering on top of baseline therapy. So first and foremost, I recommend patients go and buy a home blood pressure monitor, and I teach them how to do this. The worst blood pressure they're going to have is the one sitting in front of you when they're talking about their risk. And so I think it's a really unfair assessment to assess their BP on those grounds alone. And so I asked them to go to Chemist Warehouse. An Omron, reasonable quality, is $50. They can get a rebate from their private health as well, and get them to have some data and tell them that the importance of data is that they do this 2 to 3 times a day over the course of 2 weeks. We get really nice data points. Some of the more expensive ones can give you Bluetooth and charts, and some patients love that without getting neurotic about it. But that data is very helpful. So I commenced this gentleman on Rasuva 10, Perindopril 5. Now, whether you start them both at the same time, again, there's always a risk of side effects, and it's hard to know which of the two you've chosen. But you've got him in your clinic, you kind of want to have that opportunity to try and mitigate his risk. 6 weeks later, he comes in to see you. His BP on his machine overall is around the 120 to 130. So we're pretty happy that we've managed to optimize that well with a fairly modest dose of ACE inhibitor. His LDL has gone from 3.4 down to 1.8 millimole per liter. His HDL probably has gone sideways, up maybe a little bit with exercise, and his trigs have come down too with a really concerted effort around his diet. And so whilst you don't need to recalculate his risk, I often find that's a nice way for patients to see the benefits of what they've tried to achieve. So we've gone from 11% down to 6%. And again, that's a little bit back of the envelope, but you can at least show him his LDL has gone from a red zone to black. His blood pressure clearly is improved. And I talk to patients about what this means. Blood pressure is the pressure your heart generates across your blood vessels 60 times a minute, 60 minutes an hour, 24 hours a day. It's 100,000 heartbeats. If it's 25% higher than it should be, imagine that in your car. You're going to wear out your car very quickly. So important to explain what these numbers are and why we're chasing numbers, because John feels just fine at the moment. This is prevention. Patients feel well. You want to maintain how they feel at the moment, but we're trying to plan for the next 5 to 10 years. So to summarize this case here, I think absolute CV risk assessment has limitations, but it's a critically good conversation starter. It's guidelines and not gospel. I think it helps frame a discussion on absolute benefit, because if we attribute relative risk reduction consistently, those at highest absolute risk derive the most absolute benefit. And when we look at that number that we talk about, this threshold of 10%, that suddenly we then should think about lipid lowering and blood pressure lowering, that's a continuous variable that we have arbitrarily plucked out of the earth, plucked out of the sky. And so if you attribute someone's 10% risk and then reduce that by 30% relatively to 7%, the number needed to treat is 33. Now, I have patients sitting in front of me with a 20% absolute CV risk that I can reduce down to 14%. And they'll say, "Doc, what are you, a daily tablet for that? You kidding me?" Whereas I'll have other patients in front of me whose dad died of a heart attack in their 50s, and they say their absolute risk is 5%. Give me whatever tablet you want. Take me from 5% to 4%. I'm happy. Let's rock on. So that's a very patient-centered decision. And I think these arbitrary cut points are helpful for discussions, but remember that these are continuous variable and recognize how we came to attribute them and what it means. There's a hand up from Nat I'm going to get to you shortly. Diet and exercise are critically important for CV risk reduction, but they do not help with lipid lowering, LDL cholesterol lowering. They absolutely help triglycerides, but they don't improve LDL cholesterol. And so please manage expectations with your patients. They're likely to need tablets. I love home blood pressure monitors, but it's important to get good data. Garbage in, garbage out. If they're taking it at home and they're walking around, they're moving their arms about the place, it's not going to be helpful. So make sure that they have taken the blood pressure properly, and you get a nice little diary to come back to. Fasting and non-fasting LDL cholesterol, the last 10 years have very clearly shown non-fasting LDL cholesterol is completely reasonable, particularly in patients with normal triglycerides, but less than 4.5 triglycerides allows a computing of LDL cholesterol. So while you've got them, take your blood test. All right, questions. Already a couple come through. Nat, I think you've got your hand raised. Come off mic and have a chat. I can't hear you, Nat, if you're talking. Maybe she put up a hand by mistake. No? Any questions about that first case? Some questions there from Nat. Kate, please come off mute and would have to allow to talk. Sorry.
And
there we go.
yeah, you just need to allow them to talk.
Sorry, here I am not knowing how to use the bloody platform. Go, Nat. Can you unmute there, Nat?
I try. I'm asking them to unmute, but I'm not sure. Nat, are you there? There's a question in chat box as well. Q&A.
Why do we let Kate's got a hand up as well. Kate, do you want to ask your question? Kate Oden.
If you can't unmute yourself, feel free to use chat function or Q&A function to ask your question.
Monica, would you mind reading the question? I can't see the Q&A. I can only see the chat.
They're just asking if the slides will be available afterwards. So.
Oh, okay. Yeah, of course. I can PDF those. No worries at all.
Yeah.
All right. Well, perhaps Kate and Nat, please put your question in the Q&A.
Kate's speaker is on. I'm not sure why we are unable to hear her. She's not on mute.
Oh, good. Hopefully we can have it in the Q&A.
I think use the chat function. If you can't unmute yourself, please use the chat function to ask questions.
Yeah, terrific. All right. While you're having a bit of a think, I'll go through to case 2. So this is a 41-year-old male, and this is a case that I think is really instructive about the challenges we face in younger patients. So it's a 41-year-old male who's referred through to me with CV risk assessment. His background history included this borderline hypertension and a family history of coronary disease, which was not quite premature, but was in their sort of mid-60s. His blood pressure in front of you is 141/76. He's got a very healthy BMI at 26, really, an LDL that's elevated at 4.1, trigs are normal at 1.4, and his A1C is completely normal. And you put him into the calculator, and his Australian CVD risk 5-year events is 1%. So it's considered low risk. So what's your plan? So you can reassure this man his absolute CV risk is low. You could try and re-stratify him or reclassify him with a coronary artery calcium score. You could review him in 12 months after diet and exercise, or you could just go off the bat, commence lipid and blood pressure lowering therapy. So we'll go back to see him. So he's got a blood pressure that's kind of borderline 140/76, but his LDL is 4.1. He has this family history, doesn't quite meet criteria. Kind of a little bit about his history just smells that he's not really just 1% 5 years. So what's your plan? Well, my feeling here is that we move towards individual evaluation of lipids and blood pressure as key elements of CV risk, but I'm a slightly more aggressive individual. And so when you come to see me as a preventative cardiology, I'll talk a lot about this. So I want to talk for a bit now about LDL cholesterol. The statin era for the last 30 years has provided us with a plethora of data clearly demonstrating the relationship between achieved LDL cholesterol there on the x-axis and prospective risk for events. Here, the primary prevention trials in the dark blue diamonds and the secondary prevention trials in the light blue squares, clearly showing this linear relationship. The lower you can achieve your LDL cholesterol, the less risk you have for prospective events. And clearly the axes there differ, whether you're secondary or prime prevention, but the reality is that the biology is very consistent. What's neat about nature is it doesn't matter how you achieve lowering of LDL cholesterol. Here you can see, again, a linear relationship with achieved LDL cholesterol down the bottom on the x-axis and relative risk of events, and it's meta-regression. This is the PCSK9 trials there in that light, in that dark blue, purpley in the top right, all the way through to ezetimibe in the bottom left, fairly modest lipid lowering, LDL lowering, 15 to 20%. This relationship is very, very consistent. So it doesn't matter how you achieve LDL cholesterol reduction, this same 1 millimole per liter reduction over a 5-year period should achieve a 20 to 25% relative risk reduction. Neat biology. The last linear regression, I promise I won't overload you with slides, with data slides. There are slides tonight, but with data. So this is a neat summary, again, meta-regression analysis, Brian Ferentz, published in European Heart Journal, a very neat 2-part manuscript looking at the biological basis towards the causal relationship underlying LDL cholesterol and ASCVD. Here you can see again that same linear relationship, magnitude of LDL cholesterol reduction or exposure, randomized controlled trials here in the red of median duration 5 years. There you can see prospective cohort studies, median duration 12 years, Mendelian randomization studies of median follow-up 52 years. This is looking at natural assortment, natural variation in the genome that exposes patients to higher or lower levels of LDL cholesterol from birth. Again, what you can appreciate is 3 linear relationships, but the differences in slope is what's most notable here. And so what you can see is that if you were to treat a patient for 5 years in an RCT and achieve 1 millimole reduction, you can reduce their risk of around 20 to 25%. If you extend that to 12 years of therapy, a 1 millimole reduction, you can achieve almost 35% relative risk reduction. But if you extend that out to 50 years, so a lifetime exposure, genetically blessed with low levels of LDL cholesterol, you derive the most benefit. And it really turns on its head, this idea that, well, suddenly you turn 60 and you worry about getting a PSA, you worry about your blood pressure, and you worry about your cholesterol. When actually we know that patients who die of non-cardiac death in their 20s and 30s who have autopsies have got fatty streaks. So we really should be much more worried about John Smith in his 30s with an LDL of 4.5 than we are worried about Doris in her 70s with an LDL of 4. That patient's resilient from coronary disease, yet the exposure that that younger patient's going to have over a longer period of time means we should be thinking about intervention earlier. And it really gives rise to this concept of plaque years. In the same way we talk about pack year exposure, this linear variable. Take, for example, patients who sit in the Australian mean, an LDL cholesterol between 2 and 3 from birth. And we see that patients have got an increased risk of clinical MI at a population level in their 60s. That's when we see most MIs develop. And if you to play that back to 40 years of age is when we see on the first CT scans when a lot of subclinical atheroma starts to arise. But what if you were able to express that for our patients who, for example, have got elevated LDL cholesterol from birth, our familial hypercholesterolemic patients who have LDLs north of 5? Well, that plays out with that very steep slope. These individuals have got atheroma that develop in their late childhood, if they've got homozygous, or in their heterozygous in their teenage years. They have clinical events in their 20s, clinical atheroma in their 20s, and they have MIs in their 30s and 40s, really precocious disease. But this isn't destiny. What if you're able to bend the curve? What if you're able to reduce LDL cholesterol, even that 1 millimole per liter? You're able to push out this cumulative exposure of LDL cholesterol and push out that threshold for developing plaque, and maybe push down incident MI till their 70s and 80s. And I think this construct allows us to then think about prevention in a very different way, and why it may make a great deal more sense to intervene on patients earlier, maybe not as intensively, but to try and bend that curve. Well, this is how it kind of plays out. Here to take an individual who has got standard levels of LDL cholesterol from usual care, and their absolute CV risk over the course of a lifetime might be somewhere between 15 and 20%. You can see that reference blue line there at the top. What if you're able to reduce them by 1 millimole per liter starting when they were 60 years of age? And you can see that green line separate there. We're able to bend the curve a little later than planned, but it's go from 16 to 12%. That's great. What about at 50? Well, you bend the curve even steeper, it gets shallower. We can reduce the risk by more like 35%. and so on and so forth. So if you bend the curve earlier, this idea that we reduce the amount of load that the LDL cholesterol can provide the arterial wall, we reduce the risk of atherosclerosis. How does it play out? It doesn't mean you have to put every patient on a 12 or 80. Goodness me, not at all. In fact, if you start earlier in the 40s, you can get by with a 12 or 10 or a 12 or 20, a much lower intensity statin, and bend the curve rather than get to 55 or 60 and suddenly go all guns blazing. It's a very different approach to prevention. And this is where the field's moved in the last 3 or 4 years. So you decide to commence your 41-year-old man on lipid-lowering therapy. You explain this, the risk that he's got. Its absolute 5-year risk is low, but at 41, is 5-year risk actually that important? I want this chap to get to 60s, 70s, 80s. So 5-year risk is such an artificial, abstract, short-term target. I want lifetime risk here. So what's my LDL target? It's starting at 4.1. Well, I'm aiming for 3.5, for less than 3, less than 2.6, less than 1.8, less than 1.4. What you've seen over the course of the last 30 years is the goalposts have shifted. And Australian guidelines haven't been updated for a number of years. So we look elsewhere. I'd argue currently my plan for LDL cholesterol in patients without incident disease is around, is around the 1.8 millimole per litre. So why is that? Why is that arbitrary number? Well, just you only have to look back a few years to see how much we've come, how far we've come. So here you can see the first cholesterol guidelines back in the late 80s. Target for patients without disease, 4.1 millimoles per litre. Target for patients with disease. You've had an MI, targets 3.4 millimoles per litre. This is when we had bile acid resonance, basically nothing we could do to achieve LDL cholesterol lowering with any real durability. Fast forward now to the last 5 to 10 years, and what we can see is the goalpost shifting. As we've got more intensive therapies, we can achieve better and better LDL cholesterol goals. And so we accordingly have got lower levels of target, lower target levels. Here you can see the ESC guidance, and the Australian guidelines will look very similar to this. And it's an attempt to try and mesh the intensity of lipid-lowering therapy and the targets with proportionate risk. So you can see there the bottom right patients, those with established disease, they've got evidence of atherosclerosis on clinical or imaging grounds, or they've got risk equivalents, familial hypercholesterolemia, diabetes and organ dysfunction, severe CKD. Those patients have got the most intensive lipid-lowering therapy targets and the most intensive regimens, 1.4 millimoles per litre. Now, the reverse is true. Those patients with the lowest absolute risk, therefore, have got more permissive treatment targets. This idea that I mentioned earlier on today, this idea, is the juice worth the squeeze? If you've got low baseline risk, then the same proportionate relative risk reduction is going to be low absolute benefit. But for some patients, they're very happy to do that. And that makes sense for them. 10 to 15 years of treatment, suddenly that absolute risk accrues over time. So why do I use 1.8 millimoles per litre? Well, again, the guidelines are a little bit discordant here, but I like the Glagoff trial. The Glagoff trial looked at patients who had stable atherosclerosis, and they randomized those patients to receive evolocumab, we'll talk more about shortly, PCSK9 monoclonal antibody, or placebo. And here you can see the plot of on-treatment LDL cholesterol and change of percentage atheroma volume. So how much plaque changes. And what you can see here is this, again, linear relationship. The lower your achieved LDL cholesterol, the more reduction. So the greater reduction you had in atheroma volume, the more you leached plaque away. It's not Drano, but it does help regress a little bit. And if you got to 1.8 millimole per litre or less, almost no one progressed. So I talk about 1.8 millimoles per litre or 2 millimoles per litre thereabouts as being where I want to get to. But the reality is if you start at 4 or 5 millimoles per litre, you're not going to get there with statins or ezetimibe alone. And so you're kind of somewhat restricted by what you can access. And so this principle of ALARA, as low as reasonably achievable, which is exactly how we talk about radiation, as low as reasonably achievable. So you commence him on a couple of good questions coming through, and I'll cover those in a tick. You commence him on atorvastatin 40, which is kind of my rule of thumb, atorva 20, atorva 40. When should you follow him up? 2 weeks, 6 weeks, 3 months, or 6 months? I tend to like 6 weeks. And the reason I like 6 weeks is that you can see changes in oral lipid lowering therapies on LDL within that time frame. Now, monoclonals, siRNA is a little different, but we can see expression of the LDL receptor change when you interrupt that with HMG-CoA reductase with statins, and you can see the improvements in LDL cholesterol within about 4 weeks of ezetimibe use. So for me, 6 weeks, and that helps me cover off with a patient about how well they've gone. If I say it's in 3 to 6 months, then suddenly they're going to believe that I'm also not so worried about what I'm doing. It's not really as critical. Whereas if I cover off on this within the space of a couple of months, then I think it matches the intensity with which I'm trying to treat this individual. So after 6 weeks, his LDL cholesterol on a 12 or 40, again, around about a 50% reduction from baseline. It's gone from 4.1 to 2.3. So what's your next step? Options, congratulate him. By achieving that almost a 2 millimole per litre reduction over the course of 5 years, he'll have about a 40% relative risk reduction. Part B, do I push diet and exercise? C, do I increase a 12 or from a 12 or 40 to a 12 or 80? Or do I add ezetimibe? So for me, it's adding ezetimibe. So I've already said that diet and exercise does very modest things to LDL cholesterol. I think congratulating wouldn't be unreasonable. So statin monotherapy, very reasonable outcome there, 4.1 to 2.3. No one would really shirk at that. It's a great outcome. A 12 or 40 to a 12 or 80 in a 41-year-old makes me a little bit nervous. And the reason for that is this is data that's more recently presented. This is Rory Collins. Look at the cholesterol trialist collaboration there on the left. You can see that the proportion of individuals who progress to diabetes over the course of longer-term statin therapy. Now, we do know that statins increase the diagnosis of diabetes in patients treated for longer periods, and that is dose-dependent, i.e. a 12 or 80 more so than a 12 or 20. And the reasons for that are because we believe, again, this is specific to statins, not LDL cholesterol lowering, is because we're taking patients who are on the threshold of diabetes and then over time they're progressing at a greater rate on the statins. We think that relates some way to the receptors, but it's not completely well understood, but it has been consistent. So patients who raise concerns about diabetes, yes, it does play out, but it doesn't appear to mitigate the risk. If there was a huge risk of developing diabetes, then that would offset the benefits of LDL cholesterol lowering. So for the most part, it's very clear that the benefits of LDL cholesterol lowering, particularly in secondary prevention, far outweigh any diabetes signal. But in a 41-year-old person who you got exposed to 20 to 30 years of statins, you probably want to do regimens that are relatively statin sparing. And so instead of going from a 12 or 40 to a 12 or 80 in prime prevention, I instead add an ezetimibe. This is a study called RACING. RACING looked at comparing in patients already with an event, so not quite the same as this chappie, but they compared high-intensity statin versus a moderate-intensity statin plus ezetimibe, and they showed that the rates of attainment of LDL cholesterol was almost the same because you had better tolerability in the moderate-intensity statin ezetimibe combination compared to high-intensity statin. And I think that's where we're going to move towards regimens that don't require us to go to a 12 or 80 for every patient. And particularly for prime prevention, a 12 or 20 to 40 gets you most of the way. So I intend instead, when you've got availability of ezetimibe, take that point that there's a bit of shortage around that. That should be improving soon. But I add ezetimibe, single dose combination, single tablet. Unlike Rosusdet, which is 2 blisters, still 2 tablets, this is a single tablet, young chap. He only wants to take 1 tablet. That makes sense. LDL has gone from 4.1 to 2.1 to 1.7, and we've managed to get him to that threshold line. The comment's been raised about PBS guidelines, and I argue these are now generic. These are cheap as chips. These are $5 to $6 per month for most patients. The ezetimibe on a private script these days at Chemist Warehouse can get as low as $10 to $12. So I'd argue here that if patients are willing to pay for their statin, the addition of the ezetimibe is not a big deal. Again, there are some patients who perhaps are really struggling, and that may be enough to tip them over if they're on lots of tablets that haven't reached the safety net. But by and large, patients who are engaged around prime prevention are willing to pay for this. Important caveat here. His wife asks if he should be on aspirin. Yes, no, possibly. The answer here pretty convincingly, I think, is no, but we can unpack it. Another whole talk on its own. We used to think aspirin should be in the water pretty much. I certainly felt that when I was going through training, but a variety of clinical studies now have shown that in otherwise healthy individuals, that the bleeding cost of statin is the bleeding cost of aspirin is not insignificant. And in fact, particularly in patients who have got high bleeding risk, even if they've got high ischemic risk, the bleeding risk tends to dominate. So it's 3 steps forward and 2 steps back almost. This is a spree led by John McNeil in Melbourne, took an elderly cohort, not quite a 41-year-old by any stretch, but of a modestly high bleeding cohort risk. And they showed that the benefits were well and truly offset by the bleeding. And so we've now really completely switched around this idea of aspirin being the cornerstone for risk reduction. In fact, it really should be probably around statins and LDL lowering for the most part. Guidelines now have reflected this. This is the US task force. We don't have primary prevention guidelines in Australia that point to this, but you can see there down the bottom. Class of recommendation 3, level of evidence C, low-dose aspirin should not be administered for the primary prevention of ASCVD amongst adults of any age who are at increased risk of bleeding. Now, you'd argue this 41-year-old chap, low risk of bleeding, but in general, patients overall, aspirin seems to be falling out of favor. So I'll summarize this second case. 5-year absolute CV risk reduction, I think, is not fit for purpose in young patients. Not only are there fewer people in those lower quartile of age bracket of the overall risk factor calculator, but in fact, in the younger patients where we don't have any data, I think it's unhelpful to put them through a calculator. And I think 5 years is unhelpful for 41-year-olds. I don't want to make sure they're healthy at 46. I want them to get to 76. So I think lifetime risk or using single risk factors, particularly for this individual whose LDL is high. And the way that I talk about that is this idea of cumulative exposure. And we understand, therefore, that if we're able to reduce the load of LDL that's exposed to the blood vessel over time, we ought to reduce their risk of developing athero. I use a follow-up interval of 6 weeks. I think that's proportionate to the intensity with which I'm treating them. And for monoclonals or siRNAs, that may need to be longer to see the full effect of these agents. But for the orals at the moment, statin and ezetimibe, 6 weeks is a reasonable time frame. Any earlier than that, and again, the PBS requires you to be stable for 3 months. But the biology we see within 6 weeks. I like this idea of statin sparing. I think that a 12 or 80, super 40 may not be required for all patients. And then the primary prevention aspect where you want to be risk averse, then trying to reduce even the numerically higher rates in the high intensity group, you want to try and offset. So for me, I do talk about statin sparing. And I think there's been a general move, particularly in things like dual antiplatelet therapy, but even for primary prevention, that aspirin appears to be falling out of favor. So there's a really nice question there. Why have the guidelines changed to LDL, HDL rather than LDL? So it's not so much it's changed to LDL, it's actually total cholesterol to HDL ratio. And that is because there has been a historical attempt to try and marry the HDL data that we have. So let's go one step. HDL clearly relates to risk. We know that low levels of HDL associate with risk and high levels of HDL associate with prevention. What's been underwhelming is that all of our attempts to raise HDL pharmacologically have not translated to benefit. And so I think using the ratio sends a message that I don't think is borne out in the biology, that you can offset someone's LDL risk by having high HDL. In fact, all the mediation analyses show that for varying levels of HDL, your LDL continues to impact risk. Unfortunately, the guidelines all have used total cholesterol and HDL. This is the New Zealand Prevent, and we have adopted the same. So I think it's a real miss. I'm not on the guideline committee. It's easy to stand back and Monday morning quarterback it and sit from the cheap seats, but I think LDL is where we need to be. And I'd argue that even more than that is probably a move towards non-HDL and ApoB, but for the time being, LDL. I've got another question on the Q&A, and then I'll go to you, Blaceline. So is the young patient, what level of LDL would you consider commencing a statin? So this is where it comes down to this idea of cumulative exposure and cholesterol plaque years. Now, for me, the uptick starts around an LDL of around about 3. But that's, again, continuous variable, and it's a bit like the company it keeps. An LDL 3 becomes even more important in someone who's got impaired fasting glycemia, who's got borderline elevated blood pressure, who's got a soft-ish family history. This idea of almost looking at your insurance for your car. You're going to pay more on your car insurance if you park it outside without an immobilizer in a bad suburb, and who've got a bad credit rating, a bad driving rating. In the same way, I focus even more around LDL cholesterol when it's in the company that it keeps. So I don't have a dichotomous point, but I will say to patients that if you take your LDL cholesterol from 2.7 to 1.7, the biology still says you reduce your risk by around 20 to 25% at 5 years, but your absolute risk at lower levels of LDL cholesterol are probably lower than those with high levels of LDL cholesterol. So I hope I've answered that question, Amra. Blaceline, did you want to, you've had your hand raised there. Monica, would you mind helping Blaceline come off mute?
What is it? Sorry?
Just, would you mind helping? There's someone's put their hand up. Would you mind unmuting them?
Yeah, because I can't see their hand. Who is it?
Blaceline.
Do you know the name?
Blaceline, did you have a question? Well, the hand's been put down. Maybe it was an accidental hand.
There are questions in Q&A. If you haven't answered them, can you see
So I think I've
Q&A?
got two of them. There's a nice new one there from Jiva Priya. So is there side effects of ezetimibe? Yes, there are. There are side effects of every medication. Ezetimibe is flatulence and sometimes GI upset. I tell patients that you can blame the medication rather than the dog for a couple of days. But by and large, it settles after the first few days. I've had one patient, interestingly, who was on colchicine and ezetimibe together, and that seemed to be worse. When I added the ezetimibe, they got more GI disturbance, so maybe there's something sort of pharmacodynamically around that, or at least in their GI tract. But in general, ezetimibe is very well tolerated. It's a very modest lipid-lowering drug. It's 15 to 20% on top of statin, but sometimes it can help you get there just a little bit further down their LDL cholesterol goals. Done that one. PBS guidelines regarding statins. Yeah, ezetimibe just did that one. Yep. What are the PBS guidelines regarding commencing statins? Well, I've already mentioned that the PBS guidelines are so historical and antiquated that I don't even follow them anymore. They're all now generic. So for me, I don't even use them. I think they're all so old school. I hope that doesn't get me into too much trouble. How soon can we check the lipid after starting statin? I've mentioned that sort of 6 weeks. For me, now, if we're looking to increase to non-statin lipid-lowering therapy, you've actually got to have 3 months on a stable dose. But the biology here is 6 weeks. And one of the mantra I want to leave you with here at the end is that there's a need to overcome inertia. And I think if you continue to do it in 3 months or in 6 months or in 12 months, that's telling your patient it's not really that important to you. All right. We've done 50 straight minutes of cholesterol. Why don't you have a couple of minutes and we'll come back in literally 5 minutes, stand up, get a drink, go to the toilet, and we've got 2 more cases to come. And please keep your Q&A. Lipid subfractions, thoughts. All right, I'll keep answering questions while we're doing the break. Lipid subfractions. I don't actually order them very often. So you can order them. The question is why you're ordering them. So I think sometimes we get concerned that patients have got a normal LDL cholesterol concentration, but they may have small, dense LDL cholesterol. And in that context, rather than doing subfractions, I instead do ApoB, because ApoB then gives you a sense of particle number. But gosh, if you're going down to that pathway, I'd be happy for you to give me a buzz and we can chat about what is the right test to order, what would give you the most bang for your buck. So I don't tend to use a lot of lipid subfractions. Instead, I use other things, and we'll talk about Lp(a) shortly. But that's kind of where I take that. Couple more minutes of break. I see LDL going with keto patients. Yeah, and that's exactly the group. Yeah, well done. So the trouble with keto is that what we think is probably happening is that their LDL cholesterol concentrations are going up. Now, this is difficult because if you have more cholesterol laden on those LDL particles, your particle number may not change, but the cholesterol concentration increases. Now, that may not be proportionate to CV risk. So it's actually particle number that increases risk rather than the cholesterol concentration. Yet, historically, we've only ever measured concentrations of cholesterol as a surrogate for particle number. So yes, that is the group where subfractions can help you to look at the changes in small dense LDL. I instead use ApoB, and I think the keto stuff is really tough because diet is something that we have got with it's everything we put into our mouth. So it's the most important medicine in some ways, and yet we've got the least amount of data to guide the decisions that we're providing our patients with. So patients come to me and say, is keto safe? And I'd say, well, if I see the changes in their lipid parameters, I get nervous. And so in that context, I'd try and say to them, well, if you're planning on doing it in a really meaningful way, let's do your baseline ApoB, or in your case, subfractions would be reasonable too, and see what happens. And over the course of 3 to 6 months, we see changes in particle number. Then you have to say, well, we think that's going to probably increase your risk of athero. Now, if you don't see changes in particle number, but you see changes in cholesterol concentration, then perhaps it's less risky, but we don't have any data. Some of the studies that have been done have been observational, confounded. So we don't really have good understanding of what the impact of this stuff is long term. So, I provide some caveats to patients and say, look, we don't really know, but, if it walks like a duck, it sounds like a duck, it's probably going to be a duck. If your particle number increases, you're probably going to have more athro. So I think it's a great question, and I don't have a good answer for it, but I'm pretty honest about the uncertainty. Female patient presents with the same scenario. Is the approach the same? Yes. So we have historically undertreated women. We know that women, and we're going to talk a little bit about women-specific risk factors shortly. Women are protected from with estrogen in this 40 to 60-year-old period where we see males uptick, but they are not resilient completely. And so I will talk to patients, female patients, that their risk overall compared to males is less. There's no doubt, absolute numbers, but they're not no risk. And so for the same reasons, the LDL hypothesis fits males or females. What if LDL is normal, TG are elevated? How does management change? Great. So normal, again, normal in the eye of the beholder. What is normal? So if the LDL, say, is 2 or 2.2, but their trigs are 2.5 or 3, then we do believe triglycerides are a marker of CV risk, and we're going to come to this towards the end in the third group. Triglycerides clearly, in a monotonic way, as you increase triglycerides, you increase CV risk. When you adjust for even lower levels of LDL cholesterol, TGs remain important. The challenge with triglycerides is that they don't respond to statins, ezetimibe, PCSK9 anywhere near as well as LDL cholesterol. So instead, we have other things that we can consider. For elevated trigs, I make sure that they've got a test for A1C. For diabetes, I check their TFTs. I make sure they're not on other agents that will raise triglycerides. I talk about alcohol. I talk about exercise and diet. Triglycerides are amenable to lifestyle changes, but I may not rush down the path of statins, ezetimibe, because I won't see the changes in triglycerides. But I may instead use triglycerides as a marker for me to become more intensive about lowering their LDL. If that makes sense. We can unpack that a bit afterwards. All right, I think everyone's had a chance to get up and about, have a drink. What is the safe medicine to lower LDL cholesterol and trigs in CKD with diabetes? I think I come back to this, but I might take it now just in case. So CKD, let's talk about non-dialysis CKD. We believe are at higher risk. Those individuals have got almost coronary equivalent risk. I attribute the same process. So statins and ezetimibe, they will lower LDL cholesterol. They will not lower triglycerides much more than 10 to 15%. And in that context, I consider, again, fish oil we'll come back to, mainly as a marker of considering that agent. But in patients with diabetes and CKD, they've got the double whammy of being at higher baseline risk. So I attribute the same approach as I would in my non-CKD, non-diabetes patients. Statins are safe in diabetes. Again, I showed you the cholesterol trials treatment collaboration showing that there is this slight increased risk with new diabetes diagnosis, but they were all on the fringe anyway. So overall, the absolute benefits of CV risk reduction from LDL lowering outweigh, certainly in my mind, patient shared decision-making, the benefits of LDL cholesterol lowering. All right, great. Excellent questions. We'll come back to some of those in some of these additional cases. So my next patient is a 68-year-old female. She presents to you with annual flu vaccination. She has rheumatoid arthritis, and for that reason, she's having her flu vax. She has hypertension, which has historically been reasonably well managed on Coveram. She's reformed cigarette smoking. She had menopause in her early 40s, and you chatted to her a bit about the benefits of coming back for a heart health check. She's only seeing you for a scripts and annual flu vax. She said, well, you're 68. Let's talk about a heart health check. Her blood pressure is 147 on 75. So while she's on Coveram, perhaps we're not optimized there. Her BMI is not terrible at 31, but elevated. And her waist circumference is up from where we'd like it to be. She's carrying some central adiposity. Her LDL, when she's had her blood test done, 3.8. Her HDL, she's blessed genetically with an HDL of 2.5, so is protected from an epidemiological point of view. But her LDL is still high. Trigs are okay. A1C suggests there's some impaired fasting glycemia in a pre-diabetes range, but certainly not diabetes by threshold. You perform her absolute CV risk assessment. You put it all into the calculator. She comes out at 7%. So she's intermediate. So what's your plan? Option A, your Oz CVD risk is intermediate. So as per the guidelines, you repeat it in 2 years. You believe her risk is underestimated. You commence lipid-lowering therapy and you intensify her BP lowering. Or C, you attempt to reclassify calcium score, LP-A, other things? I think B or C are both reasonable here, and I think it probably comes down to what your patient thinks. Let's talk about it. So non-traditional risk factors, we have historically focused on modifiable risk factors: LDL cholesterol, blood pressure, smoking, exercise and weight, diabetes. But there's a greater understanding that in fact there are other conditions that clearly impact CV risk that aren't in those same buckets. So we know inflammatory conditions, that's ulcerative colitis, Crohn's, HIV, hepatitis. These conditions all have got an inflammatory milieu. And we know that atherosclerosis, the development of it, and the destabilization of plaques all has an inflammatory basis. So inflammatory conditions now, in my mind, red flags. They're not in any of the calculators, but they clearly impact CV risk. More than that, we recognize now there are female-specific risk factors. And I mentioned a couple here: early menopause, gestational diabetes, preeclampsia. We know that the childbearing process is a stress test for all of our systems, and particularly the cardiovascular system. And so those features impact and put a patient, in my mind, at high CV risk, even though they are not considered traditional reclassification factors. They absolutely make me think about that individual. I've mentioned depression and mental health already as a way to reclassify individuals. But health literacy is another one. It comes down to a little bit around social deprivation, and that does correspond or correlate in some ways. But patients with lower health literacy, we also know, are at higher CV risk, but may not play out in the risk factor calculator. So on those grounds, she's got this inflammatory condition she's had for some time. It's variably well managed. She still gets some small joint arthralgia. CRP is sort of mildly elevated historically, but she's still on a DMARD, hasn't needed a BDMARD. So you recommend lipid-lowering therapies. You consider her to be high risk, but she wants a bit more information to understand the risk benefit. She's been on therapies before, and she adds, isn't my HDL protective? So what's your plan? Options, as I said, review in 2 years with a repeat assessment. You recommend calcium scoring, you recommend LP-Little-A, or referral to a cardiologist. I didn't put the answer to that one, but I would have said in my mind that it'd be very reasonable to consider, to be honest with you, B or D. And I think I would see a number of patients who are referred in for a more detailed discussion around their risk factor modification and the role of risk factor modification. But I think in my mind, calcium score here might be quite helpful. So what is coronary artery calcium? So coronary artery calcium is abnormal. We should not have coronary calcification in our arteries. Even as we age, calcification is not a normal process. Coronary artery calcification can reclassify individuals, particularly those who are intermediate in the absence of coronary artery calcium, have got a very good prognosis and can be de-risked potentially to a low risk of an event at 5 years. Not no risk, but a lower risk. But those with coronary artery calcification, where there's smoke, there's fire. They could be reclassified to being high risk. I use them particularly for adherence. If I can show a patient there, you can see the difference between someone with the LAD and circumflex, no calcium on the left, calcium on the right. If I can show them that their arteries have already got rust in them, that's a pretty compelling reason to consider lipid and blood pressure lowering therapies. Now, I don't want to scare them, but I want them to understand, well, we've actually got the disease already. We need to work out ways to prevent it from progressing. It's non-contrast. It takes literally more time to clock in to have your scan than it does to do it. It's about 2 lots of a screening mammogram as far as radiation is concerned. It's standardized. It should be the same in Ipswich as it should be out at Golden Grove. There are incidental findings. So, once you've seen things, you can't unsee them. So we certainly do see lesions in the lungs, for example. There is an out-of-pocket cost. And so for that reason, the Australian guidelines have not recommended calcium scoring by and large, because you couldn't have had an inequity issue. You can't have patients having to pay for things that they couldn't otherwise afford. So it's still being left as a consider. So at the moment, it's about 100, 150 bucks. Now, what is coronary artery calcium not? So calcium scoring, so the actual score that they attribute based on the calcification, is not diagnostic for chest pain. It can be used to reduce the risk of it being a coronary cause of chest pain, but it's not helpful for a diagnostic test for chest pain. It doesn't diagnose atheroma. It diagnoses the very tip of advanced atherosclerosis, this idea of the tip of the iceberg. What we're not seeing is soft lipid-rich plaque. And we know that in the younger patients, particularly ages 40 to 60, around about 20% of those people who have a calcium score of 0 will have fibrofatty plaque that hasn't yet calcified. So to say someone's got a smooth calcium score and no plaque is providing the wrong information. Calcium score of 0 has a low risk of an event at 5 years. It doesn't mean you're free of plaque. You're free of calcification. What's its role? I think it's helpful in low and intermediate risk. It is not useful in high risk because you're already committing that patient to therapy. And if you show they've got no calcification, doesn't mean they've got no plaque, and suddenly they'll ask questions, well, why am I doing this? Again, it's not been used in high-risk patients. I've mentioned already there's a cost around it. So if that's calcium scoring, let's juxtapose that with CT coronary angiography. So what is CT coronary angiography then? This is using cannula in the arm, we're giving contrast, and we're actually doing the same thing that I would do via an invasive approach, and we're lighting up the coronary tree. It visualizes the arterial wall. You can see a beautiful picture there of one of our photon counting CTs, and you can see those linear calcification in the actual arterial wall. You can see that a barometer of vascular health shows you high-risk features. There is some ongoing work now with sub-millimeter resolution to look for evidence of high-risk plaque features. And it really has undone our whole metric around primary and secondary prevention. Someone can have clear atheroma, but not have yet had an event are considered primary prevention. But actually, they've got atherosclerosis. They've got the disease. So what does primary prevention mean anymore? Addressing risk factors, where now we can actually see the disease. So I think we're going to move to an environment where when radiation doses come down, contrast use is lower, market pressures drive costs down, this I think will become our test in patients in their 40s and 50s. It's currently ordered by specialists. You need chest pain clinics, private firms, etc. There are ways to try and get access to CTCA, but at the moment it's for symptomatic patients and not for risk assessment. I try and find ways to do CTCA because I think it's a very helpful test for patients. I mentioned Lp(a). So lipoprotein(a) is kind of becoming more and more interesting, even though we've known about it for over 30 years. Lipoprotein(a) is, for all intents and purposes, like LDL cholesterol's evil cousin. It's the same sort of size. It is able to penetrate the sub-intimal space. It can promote atherosclerosis. And we think that pound for pound, it's probably more atherogenic than LDL cholesterol. However, it's far less common. So it's only elevated in about 1 in 5 individuals. It's almost 90% genetically determined. So you can cascade screen these individuals, and there's a large ancestral component to it as far as racial variation is concerned. It correlates very well in a monotonic stepwise way with risk of aortic stenosis, as well as atherosclerotic cardiovascular disease. Unfortunately, the assays haven't yet been standardized, so it can be reported in milligrams per deciliter, in which case less than 50 is considered normal or low risk, or should I say more than 50 is considered at higher risk. And if it's presented in nanomole per liter, 115 is the benchmark for considering someone at higher risk. It's about $50, sometimes $80 out of pocket. It actually only costs them about $10 to do. So there's a markup on this. And hopefully as we see this become more and more mainstream, that we'll see the price come down. And what's quite exciting is we've actually got therapies that are coming down the pike that we've seen reductions in Lp(a) cholesterol, or Lp(a) levels, of up to 90%. So we'll have the answers in the next year or two as to whether or not lowering Lp(a) actually improves outcomes. But for the moment, the way we view it is a way to intensify risk factor control. If we see Lp(a) that's elevated, well, we know that we need to make every other poster winner. Let's make sure the blood pressure is controlled. Let's make sure their LDL is controlled. Let's make sure the sugar's controlled. That's the way we use Lp(a). So you've done testing for this woman. Calcium score comes back at 920. Pretty high, 90th centile for a female. Her Lp(a) comes back, that should be little a, at 180 nanomoles per liter. So that's elevated compared to a reference point, certainly more than 115. So she gets it. She's like, okay, I've got it. Yep. I will benefit from risk factor modification. I've got, evidence of early atherosclerosis. So what's your plan? So A, optimize her BP meds. You remember that her blood pressure was sort of north of 140 on Coveram. You add Reserva 20, you add aspirin, optimize her rheumatoid. She's still got some arthralgia, CRP's up a touch, or E, all of the above. Probably an easy answer, that one, all of the above. So why? Well, some interesting data. I've already told you about aspirin being out of favor. Perhaps the one group we think may be of benefit is Lp(a). So we think Lp(a) is pro-atherogenic, but we also think it's pro-thrombotic. And here you can see a nice sort of sub-analysis from NHANES in the US. Patients with elevated Lp(a), observational only, so subject to confounding, those with regular aspirin use in red, those without aspirin use in blue, lower rates with aspirin use. Now, this is right for a randomized clinical trial, but for the moment, the biology kind of fits with this as well. So this is one group where I'd say, well, actually, maybe aspirin may be a benefit here, particularly in patients with lower bleeding risk, where the competing risk of ischemia probably becomes more important than bleeding. I've already heralded this idea that Lp(a) lowering is coming down the pike. This is an agent called lepodisiran, and an siRNA reduces Lp(a) by up to 95%, almost silencing Lp(a). And we'll wait to see in the next couple of years whether that improves outcomes, aortic stenosis, atherosclerosis, an exciting space that, historically we've focused on LDL. Now we've got something new to look at. So I'll summarize this case. I want you to consider non-traditional risk factors. And I know that they're not in the risk calculators, but with this particular woman, you think her inflammatory condition for over 20 years has probably set her up for more atherosclerosis. And really, when we're starting to consider intermediate risk patients, maybe that might be enough to tie break. Consider opportunities for reclassification. In patients who want to understand their risk in greater detail, just doing LDL cholesterol may not be sufficient. So understanding family history, even if it's on the fringe, someone who's had an MI, their dad who's 56 rather than 54, don't suddenly discount it. I mean, that stands to reason. Ethnicity, South Asian genes we know are precocious with respect to atherosclerosis. Coronary artery calcium may be helpful to help show patients with adherence, and it also allows a robust discussion. Again, it's not that they don't have plaque, it's they've got a low event rate at 5 years, so low risk. I've already mentioned this tonight that HDL cholesterol clearly relates to risk, but it does not cancel out LDL cholesterol, despite what has been put in the guideline, and which is really frustrating, I think, that we've continued to use the TC-HDL ratio. I've mentioned that aspirin's kind of fallen out of favor, but particularly in patients with this pro-inflammatory, pro-atherogenic, pro-thrombotic milieu of elevated Lp(a), maybe that is the group that might benefit most from being on an aspirin. So I'll pause there for questions on this case, because I think that's it's slightly different to the early cases we've presented. I think the value of reclassification, I think, is becoming increasingly important because we're seeing this intermediate group. Again, I think this challenge about a 5-year horizon, I think, is problematic because patients don't want to live for 5 years. They want to live for much longer than that. So as you increase the time frame of observation, the event rate increases, your absolute CV benefit increases. So I often think more about 10-year risk, 30-year risk, and the US guidelines actually go down that path of 10 and 30-year risk. So I don't think there are any new questions in the Q&A. So we can probably keep going. And very keen for you to add them as they come, and we can pause or we can pivot towards the end of this last case. This is a slightly longer case. So I want to walk you through this chap who I looked after in my first, this is not his picture, obviously, it's a stock photo from Google Images, thanks Google Images, a 45-year-old male who was brought into the emergency department with chest pain for a couple of hours. He thought it was reflux. He'd gone through a pack of quickies. His background history is that of having lifestyle, non-medicated hypertension. Much like our first chap, he had this borderline hypercholesterolemia and had been a reformed smoker. And around about 3 months earlier, on the account of Shane Warne passing away, he ended up with a stress echo. And as is often the case, 3 months later, here he is presenting with an acute coronary syndrome. The critical piece here is that stress echo looks for obstructive coronary disease, not for vulnerable plaque. So you absolutely can get an ACS despite having had a normal stress echo. This is his not subtle ECG. Inferior ST elevation, high lateral change in those 1 on AVL leads, very concerning inferior STEMI pattern. So appropriately, this man brought in by his wife straight into the angiogram suite. This is our first picture, diagnostic catheter there coming from the north. Angiogram of the right coronary artery, contrast here in black. You can see this abrupt hold up in the mid vessel. This is an atherothrombotic lesion that's explaining his inferior STEMI. Wire down across that balloon. This is 2.5 millimeter caliber balloon, opens up the vessel. And what you can see once we've restored flow, his pain's improved. You can see these 2 lesions in his RCA that have had a plaque event. Thrombus has formed, reduction in flow, STEMI. That's the underlying biology here. We then place a large, long stent, 4 millimeter, cover up those lesions, and patient's feeling $1 million. The pictures look terrific. We've squished the plaque out of the way, but ultimately the work is just beginning. And here you can see his left-sided disease. So that's his right coronary artery. Here is his left coronary artery. And you can see heading from top left to bottom right, LAD and its branch vessel diagonals circumflexing the skyline there. And you can see there on the right, the knobbly amount of plaque that he has around that diagonal network and the septal heading towards the bottom left of the page. there's clearly a lot of plaque there. And that whilst it's not obstructive, it's not 50% or more, there's a lot of plaque burden there. And so this gentleman comes to our ward feeling $1 million. He comes back with a transradial band on his wrists. That angiogram wasn't too bad. But if we don't address his risk factors, we've just squished the plaque out of the way. It's like we've emptied the bath and left the tap on. So we must address his risk factors. As you would see from our discharge summaries that can occur 2 months after the patient's buddy left our ward, they have a very short length of stay, 2 days now for a non-STEMI, uncomplicated STEMI, 3 days. Troponin peak of 15,000, decent event, but despite that troponin, his regional wall is only mild and he's got normal overall LV function. So thank you to his wife for bringing him in. He's not had a big infarct with respect to his LV function being impacted. His LDL is 3.8, his trigs are up at 2.9, he's slightly overweight. He's discharged on the sort of the Fab 5 of aspirin, Tycag, high-intensity statin. Again, it's a secondary prevention. We want to go for high-intensity statin, perindoprol and metoprolol. We can talk about metoprolol at the end here. Metoprolol is kind of coming a bit out of favor for patients who have an ACS with normal LV function, but for the time being, this is what patients are mostly discharged on. And when I saw him in clinic, what was very clear to me is that such a short length of stay means patients are like deer in headlights. They don't often appreciate what's happened. This idea that we've fixed his artery, tablets will settle down the other ones, and my cholesterol wasn't terrible. These are all things that they picked up on the ward. And you think, gosh, we need to do a much better job of our cardiac rehab if patients leave with these sorts of messages. So he tends to see you in 6 weeks. His LDL has gone from 3.8 on the high-intensity statin down to 2.1. So we've had that 50% reduction. So we're pleased that the high-intensity statin is being taken. He's clearly adherent. We're not quite where we want to be as far as that target's concerned. So what's your next step? We add an ezetimibe. Do we switch the atorva 80 to Rasuva 40? Do we add the PCSK9 inhibitor? Or do we reassure him is close enough, good enough? Give you a couple of seconds to think about that. Add ezetimibe, switch to Rasuva 40, add PCSK9, for sure is close enough. Well, I hope I've convinced you tonight that you've got to go in this stepwise fashion at the moment as far as our reimbursement's concerned. So here, the addition of ezetimibe is the gateway to getting us into the PCSK9s. I've already said there's no daylight between atorva 80 and Rasuva 40, very much the same. Can't yet add a PCSK9 without trialing ezetimibe. And I'd argue that he's not close enough. Close enough here is 1.4 millimoles per liter. We're not where we need to be. A lot of the guidelines now are moving towards combination therapy upfront to try and avoid this stepwise commencement of therapy. Atorva 40, then atorva 80, then ezetimibe, then PCSK9. Suddenly 9 months have gone down the track. Wouldn't it be great if we could have patients started on combination therapy in hospital? It would make your job easier in the clinic to just add in one agent rather than have to go to 2. And so we are currently trying to almost interpolate what patients need to be on. If they start with an LDL of above 3.5 millimoles per liter, a 50% reduction on a high-density statin is not going to get you to 1.4. So I often will try and have patients starting on Atozet when they leave hospital so that the next review we see them, they're going to be PCSK9 eligible. Now, the PBS guidelines require us to be a bit more creative than that. But again, I'm just trying to be what I think is in the patient's ethos and what we're trying to achieve here for our patients at high risk. So what data do we have to support this idea of very intensive LDL lowering early on post an ACS? I won't labor the details too much, but this was a study done in Australia called Huygens, led by Steve Nichols. They took patients who had an ACS, had a stent to a vessel, and they took another artery that had a 30% plaque, and they did an OCT, which is a very high-res image of that plaque, and they randomized those patients, if they had vulnerable features, to receive evolocumab, PCSK9 monoclonal, or placebo, and they repeated the OCT at 12 months. And this is what they showed. We always put the best looking picture in the figure. Top left, you can see there this thin capped fibroatheroma, this idea of a vulnerable plaque, that little thin rim of light yellow inside of the artery. And after 12 months, we showed that there was a thickening of that fibrous cap. We made plaque more inert. We turned it off. We made it less vulnerable. And in the same way I've shown you linear regression about LDL cholesterol and risk, here you can see it on the right, the change in fibrous cap thickening, the making of plaque more inert, was much more likely to occur if you achieve lower levels of LDL cholesterol. Really neat data suggesting that actually what we're achieving here is at the artery wall, turning plaque off if we're able to get LDL cholesterol down nice and early. What does it mean to patients? Well, I show them what it means. This is what a plaque looks like. I showed them this in clinic. You've got a lipid-rich pool, you've got inflammatory mediators, you've got crystals, a bit like gout. and that encroaches on the lumen, and you have this thin fibrous cap, which at any time can burst open and cause a plaque event. If we're able to get your LDL cholesterol down below 1.4 millimoles per liter, we thicken that cap, we make it more inert, we make it less likely to be vulnerable, and we reduce your risk of an MI. Patients don't feel any different if their LDL goes from 3.5 to 1.4, but if we can show them what we think is happening at the arterial wall, it has some meaning to them. Again, patients aren't pot plants anymore. They want to understand why we're doing what we're doing. I've shown you this already. This patient's at the bottom right quadrant. They've got the lowest LDL treatment target, the most intensive regimen. We get the most bang for our buck here with LDL cholesterol lowering. And yet, despite this plethora of data, it's very clear in every registry you look at, less than 1 in 3 patients, more like 1 in 5 patients, you can see there in that hollow bar at the top there, 18% of patients achieve an LDL cholesterol of 1.4 millimoles per less at 12 months. We just don't get there. And part of it relates to inertia. Part of it relates to us not demonstrating to our patients how important it is to change medications. Again, when you start a new medication, you always have to sell it to the patient. It takes time, effort. Patients are often, don't feel any different. If it ain't broke, don't fix it. But we actually know that if we can achieve low levels of cholesterol, there's much less risk of them having a repeat infarct, needing further stents. So you commence ezetimibe, you attend your clinic for review 6 weeks later. You've done your 6 weeks, LDL 3.8 down to 2.1, and you've achieved that additional 15% lowering to 1.9. His trigs are 2.5 still. So what are your next step? A, you add an evolocumab, the Repatha. You add an inclisiran instead. Or you reinforce adherence. I mean, we've achieved 50% lowering with a statin, another 15% with ezetimibe. I think he's probably adherent to his medications. I'm not sure that's going to add much. Or because his trigs are up, you add a fibrate. So A, B, and C are probably all reasonable. Again, we always have to reinforce adherence. We know that adherence is very rarely asked about in our clinic. And if you don't mention it to patients, you don't talk about, you don't normalize the difficulty about taking regular tablets, then it can skip under the radar. But I'd say here, from a biomarker point of view, he's probably taking his tablets. PCSK9s are where we need to go. So some slight biology, love the pharmacology here is nice. PCSK9 is secreted from the liver. We know that it binds to the LDL receptor. As it enters, as endocytosed and attached to the LDL, it's then targeted for degradation. There's a natural recycling of the LDL receptor driven by the presence of PCSK9. Well, what about if you inhibit PCSK9? Well, if you inhibit PCSK9, the LDL receptor can simply just move back straight up to the LDL, to the surface of the hepatocyte, and continue to bring in LDL cholesterol or LDL particles. So this concept of PCSK9 inhibition therefore makes a great deal of sense. You then reduce the amount of intracellular you reduce the amount of PCSK9, increase the expression of LDL receptors, you reduce LDL cholesterol overall. You can achieve that through 2 key ways. I'm going to come to that in a second, monoclonal siRNA. Fundamentally, though, the addition of PCSK9 makes us rethink our whole argument around cholesterol lowering in the same way we talk about blood pressure lowering and diabetes. This is a multi-drug disease. If you tell patients they're going to need 1 lipid-lowering therapy and they come back and you're going to talk to them about a second and a third agent, even an injectable, that's a much harder sell than if you say up front, you say, do you know what, you're starting at 4 millimoles per liter. We know you're going to need at least another oral and probably an injectable. In 6 weeks' time, that's a much easier talking point than having to tell them, oh, you've fallen a long way from where we need to be. We're going to add in more therapies. In the same way, patient comes in you with a blood pressure of 190 on 100, 2.5 of Coversil is not going to get you there. Then you're starting combination therapy. Do this with diabetes. We now need to reframe this as a multi-drug disease. So what data do we have to support that approach? The use of PCSK9. I've mentioned about the arterial wall. What about clinical outcomes? The biology is great, Adam, but what about clinical outcomes? This is data from the FOURIER study. FOURIER was presented now almost 10 years ago, started enrollment almost 10 years ago, presented in Washington, evolocumab versus placebo in patients with established disease. You can see there around about a 15% relative risk reduction, but those curves continue to diverge, this idea around cholesterol years. What if we were to follow them slightly further? Well, in the open label extension, we did do that with 6,000 patients of the parent 27,000, then were switched either from placebo to evolocumab or continued evolocumab if they're in the parent trial. Here you can see placebo-treated patients in blue, switched to evolocumab, a 60% reduction in LDL cholesterol. That's what we know the drug does. But what was important to see is those patients who were on evolocumab in the trial, there was no diminution of effect. They continued to sustain the benefit out to a total of almost 7 years follow-up for some of these earlier patients prescribed the drug in the trial. And so then when you do a post hoc analysis looking at achieved levels of LDL cholesterol here, the lowest levels of achieved LDL cholesterol, 0.5 or less, very low levels, the lowest risk of cumulative incidence of MACE over time. And again, this monotonic relationship, the lower you can get, the less risk you have for further recurrent events. So it played out in statins, it's playing out in PCSK9. Inclisiran, new kid on the block, now available on the PBS June 1, same criteria as evolocumab, established disease, not to target, with enrichment factors. And you'll need to go back on the PBS to remind yourself, but diabetes, end organ dysfunction, indigenous, multivascular disease, recurrent events, polyvascular disease. How does inclisiran work? It's another whole talk. Small interfering RNA, 2 strands, bound to this GalNAc, which is a sugar moiety, allows it to make its way with very high specificity to the azioglycoprotein receptor, located only on the hepatocyte, binds together, binds nowhere else really. Within 2 hours, it's sucked all of the inclisiran into the hepatocyte and then is endocytosed. Once it's in the hepatocyte itself, it then breaks up, the receptor goes back to the surface, and the GalNAc moiety then degrades. And the inclisiran, this double-stranded siRNA, then binds to what's called the RNA-induced silencing complex. That is part of the cell's natural machinery to manage mRNA. We're not creating the risk that's in there already. What it simply does is once it binds to this RNA-induced silencing complex, the passenger strand comes off and the guide strand remains. And what's really neat about the biology here is that the guide strand is the exact Watson-Crick base pair complement, A's to D's to T's, G's to C's, to the target mRNA. And in this context, it's the mRNA for PCSK9. Once it sees that, it binds in that complementarity way at the RISC complex, degrades the mRNA. That's the recipe book for producing PCSK9. If you remove the recipe book for PCSK9, you can't produce PCSK9. If you don't produce PCSK9, then the LDL receptor can continue moving its way back to the hepatocyte cell surface, continue to remove LDL particles. A very neat way to reduce LDL cholesterol. What's neat about this way particularly is that the dosing interval is every 6 months rather than 2 weekly, which is what the monoclonal does. It mops up the PCSK9 once it's been produced. This stops it being produced in the first instance. So what are the comparisons? Such an important question I'm asked all the time. Monoclonal on the left, siRNA on the right. Repatha on the left, inclisiran on the right, or the Leqvio on the right. The frequency of the monoclonal is 2 weekly. We can no longer get the monthly auto-injector, so it's 2 weekly versus 6 monthly after the booster. So when you start Leqvio, baseline, 3 months, then 6 monthly. Unlike the monoclonal, which is taken home and injected by the patient, the siRNA is injected in the healthcare setting. So in parts of South Australia, currently that is in either GP nurse clinics or it's with me and my clinic. And there's a scope for pharmacies to be able to inject patients as well. Potentially that's occurring in Victoria and Queensland. That will be here soon. The experience is very different. We've had hundreds of thousands of patient years experience with evolocumab and alirocumab. Alirocumab no longer available, but evolocumab, whereas we're only relatively early in the clinical exposure for patients with Leqvio. So patients who are concerned that we haven't yet had years of experience, the monoclonal is a bit more tried and tested. The LDL lowering is a bit more potent with the monoclonal compared to the siRNA. That relates to the production of PCSK9 outside the liver. But in general, 60 versus 50, pretty similar. We've got outcomes data, FOURIER for evolocumab, ODYSSEY for alirocumab, the siRNA, Leqvio. We are waiting the data from Victorian to prevent and Orion 4, which will come in the next 2 years. And that will then guide reimbursement in a variety of other areas. So he tries evolocumab. He wants to give that a crack at home. He likes the idea of the independence, but he actually struggles with adherence, and he admits to forgetting it. It ends up being every 3 to 4 weeks. Suddenly you have these spikes of LDL cholesterol. So he accepts that actually inclisiran might be a better approach for him. LDL goes from 3.8 to 2.1 on the statin to 1.9 on ezetimibe, and then down to 0.7 millimoles per liter on the inclisiran. A really good response, over 50% reduction. His trigs still sit at 2.5. And he says to you, well, is such an LDL such a low LDL safe? Do I need to be on everything else you've got me on? Options: A, cease statin. B, cease ezetimibe. C, congratulate him and continue everything. I think I'd get this question twice a week. The answer is you congratulate him and continue everything. The first thing to say is that the assessment of very low LDL cholesterol really should be done directly rather than indirectly. The Friedewald equation actually breaks down. And so we're probably not getting a very accurate measure at very low LDL cholesterol levels. But the reality is it's incredibly safe. In fact, we have got genetic studies that show patients who are blessed with PCSK9 variants from life have got lifetime levels of almost undetectable LDL cholesterol. They have longevity. They don't have dementia. They've got resilience from cardiovascular disease. So it absolutely is safe. And what's important to note is that the trials that have been done of these agents have been on top of statin, on top of ezetimibe. So removing those, therefore, gives away the benefits that we've just taken so much time to get to. Now, patients who get LLT derangements, sure, take off the statin. Patients who get muscle aches, absolutely take off the statin. But in general, the lower you can achieve your LDL cholesterol, the less likely you are to have further events. Patients often want to understand about their foggy head or cognitive impairment and all these other things. This is an assessment of the Ebbinghaus trial, which was a subgroup of the Fourier study, evolocumab versus placebo. This was looking at a executive function, spatial working memory impairment, which is an assessment that was done as a Cambridge instrument in the study. And we can see there's no change overall throughout the study. No suggestion they got any better, but certainly no suggestion they got any worse. This is very important because patients often say, well, hold on, if I've got very low levels of cholesterol is important for my brain. Am I going to have issues with memory impairment? There's no data to suggest that. In fact, every cell that requires cholesterol can produce its own amount of cholesterol that it needs through the cholesterol biosynthesis pathway. There's no additional need for circulating cholesterol. Very safe. Congratulate them. They're very lucky. He asked you about trigs at 2.5. There have been a couple of really good questions tonight about triglycerides. Are they important? A, they're a risk marker. B, they're a risk factor. C, they're probably important, but what can I do? Maybe add a fibrate. The answer is it could be A, B, or C, to be honest. We've seen a lot of vacillation around the data suggesting this is a risk factor. It's causally related, and maybe triglyceride-rich lipoproteins, a subpart of triglycerides, are indeed causal. But we also have chylomicrons, which are massive, come from the intestine. They do not enter the subintimal space. They are not atherogenic. So it probably is a mixture of risk factor and risk marker, but they are important. So what can I do about them? I've already alluded to this tonight. This is data from the Danish experience that clearly show with increasing amounts of triglycerides there in the x-axis, an increasing risk of the composite CV outcome of CV death, MI, stroke, or revascularization. Clearly, triglycerides relate to risk. You say, well, yeah, but triglycerides also associate with diabetes, obesity. Sure, it's just confounding. Even when you adjust for each of those things, triglycerides between 2 and 5 still relate to risk. But what about if you get good levels of LDL cholesterol? This is data from Prove It there on the right. Patients achieving an LDL of 1.8 or less, broken up into trigs of 150 milligrams per deciliter, higher or lower. You can see there those who have higher levels of triglycerides, despite low levels of LDL cholesterol, continue to sustain excess risk. This idea of residual risk clearly is impacted upon by elevated triglycerides. So what do we do about it? Well, historically, we've used fibrates, gemfibrozil, fenofibrate, from the data that really is now 20 to 30 years old, before we had statins as mainstay, before we could achieve very low levels of LDL cholesterol, before we had potent antiplatelets. So the most recent study that's been done was this one, prominent, of pemafibrate in the group that ought to benefit. High trigs, low HDL, this atherogenic dyslipidemia. It ought to have been the sweet spot, the wheelhouse for where a fibrate could improve outcomes. There you can see on the right, pemafibrate compared to placebo-treated patients, that those KM curves, those cumulative incidence curves completely overlap. No benefit. This has really impacted my prescribing. Patients who have got polypharmacy, fibrates for CV risk reduction, I'm taking them off them. Patients who have got retinopathy, or I think they might have microvascular disease, maybe the fibrate has a role. But in general, for CV risk reduction, despite trigs of 2 to 5, I'm taking them off these agents. They've clearly got no CV benefit. That's in distinction to patients who've got trigs of 15, who get pancreatitis, we know they can lower triglycerides by about 30%. It just doesn't impact their CV risk. Important differences in cohorts. So what can we do? Well, this was pretty exciting data from a couple of years ago now called the Reduce It trial. Fish oil is a talk on its own. We know that Blackmore's fish oil, over-the-counter, low dose, does not improve CV outcomes. But if you give very high dose fish oil, we're talking like 15 tablets of the over-the-counter, there is the suggestion that you could increase levels of omega-3 fatty acids in the bloodstream, in the red cells. That would be anti-atherogenic, anti-inflammatory, could improve outcomes. This is the study that demonstrated that. Reduce It, highly purified icosapent ethyl, icosapentaenoic acid, 2 tablets BD, compared to placebo in patients on statins with LDLs below 2.6, a 20 to 25% relative risk reduction. This is on the PBS from October 1. It's odorless, much better than your Blackmores. And for patients who are eligible and already paying for Blackmores, this will be cheaper for them, much better drug. Blackmores literally is taking a whole bunch of fish that are taken, trawled off the ocean and crushed and put into some sort of liquid and then made into a tablet. This is literally purified 99.3% medicinal grade fish oil. It's like oils ain't oils, completely different. This is an option for this chap, particularly who's got a well-controlled LDL, but whose trigs are elevated. I've mentioned already, this is on the PBS now from October 1, streamlined authority. There's no phoning up for this, which is what we're currently having to do for Leqvio. This is straightforward and easy to do. So I'll summarize this case. Patients with high absolute CV risk, LDL cholesterol must be considered combination therapy, particularly when you're starting with an LDL of above 3.5 millimoles per litre. You're just not going to get to 1.4 with 50% reduction by itself. These changes that we can achieve occur at the arterial wall. We've got intravascular imaging to support the outcomes data, and I show patients what that looks like. Again, they don't feel any different with different numbers, but they look very different when you see the arterial wall. You now have the keys to prescribe these agents. This has been in the guidance since the end of 2022. It makes a great deal of sense. In our ivory towers, we see our patients 3 times a year. You're seeing them 10 to 12 times a year. You're doing the bulk of this work. Absolutely, you should have the keys to do it. This idea of in consultation with a specialist, I think, is a very broad church. I try and make sure that our discharge summaries identify patients who are eligible for a PCSK9 based on the risk factors that they've got. And if their LDL remains above 1.8 millimoles per litre, that for me is in consultation with a specialist. I'd love to receive a phone call, an email about any patients. If you're interested in starting a PCSK9, I want to hear from you. Please do. In consultation should not be a barrier. We need to move towards overcoming inertia. I really struggle with this idea of 3 monthly intensification, but the PBS requires us to do that. Again, I sometimes creatively interpret some of that guidance. When we talk about triglycerides for CV risk, consider deprescribing your fibrates if they're just on board for CV risk. If they're there for retinopathy, microvascular function, I get it, or triglycerides for pancreatitis reduction, fibrates have a role. However, instead, consider fish oil, consider icosapent ethyl for SKIPA as an option that's now on the PBS. So I'll pause there for questions. I finished with 20 minutes or so, but I'm also able to give you early minutes. It's been a lot of lipids to talk about. Keen to hear any thoughts. Please come off your mute. If you've got any questions you want to raise through or through the Q&A, I'd love to hear your thoughts. Hopefully we had a few that made it through all the way to the end. I've left my email there, so please, also the sa.gov one, please do reach out if I can be of any assistance.
I have allowed them to talk. I have asked them to unmute themselves. So anyone has any questions, please unmute yourself.
With someone with a 0 calcium score, is there any value in repeating it? Great question. So the guidelines will say a warranty period of around about 5 years. So the event rates for patients with 0 calcium score are very low at 5 years. And so it makes sense then to consider repeating it. Now, in patients who have got risk factors that haven't been controlled, so on the account of a 0 calcium score, they therefore have continued to have an LDL of 3.8. and they continue to smoke, that would be a patient where absolutely to try and help convince them a calcium score repeat might be reasonable. But I certainly wouldn't repeat it any more often than that. Once you have done a calcium score and you start a patient on a statin, you can't repeat the calcium score. And the reason for that is that we know that statins actually calcify plaque. And we think that that is actually a response to injury, or it's reparative, that actually we're making plaque more inert by calcifying it. So once you've started a statin, don't repeat the calcium score. If they go from a calcium score of 50 to 100 because you've started a statin, then the concern the patients will have is, well, hold on a sec, have you made me worse? Actually, it just becomes a less useful biomarker. Great question about calcium score. You can see those other Q&As we've done. LDL normal, TG elevated. How does management change? We've done that one too.
All good.
It's a long 2 hours of lipids, that's for sure. I hope we've still got most of you there towards the end. Thanks so much for listening, Monica. Thanks for having me. Thanks to the SA.
Thank you. Thank you so much
Country Health PHN.
Thank you for presenting, Adam. It was lovely listening to your presentation, and I hope everybody enjoyed it. I would like to thank CSA PHN for funding this session as well. And please don't forget to complete the evaluation when you exit the webinar. So we look forward to your feedback. Thank you so much, everyone.
Thanks. Thanks.
Have a good night.
Bye.
Anything you would like to share? Any feedback for us, Adam, from your end?
No worries.
No?
I can certainly send through the PDF of my slides if that's helpful for attendees, and keen to hear how we can make it more informative, or if it's the right pitch, more or less content, more or less questions, and maybe some pre-polling perhaps might be helpful. But I'm very, very happy to give up the time.
Sure. Thank you.
All right. Have a good night. See ya.
Good night.
Bye.
Adam.
Bye.
Adam.
Yes.
It's Jenny Cook-Foxwell here. I just remember.
Jenny Cook-Foxwell.
Yeah,
Goodness
hello.
me.
I remember
hello.
the time when you were in third year and Anton and I said, he will do great things. Proven.
And here we are chatting about LDL on a Wednesday evening, Jenny. Thanks for joining. I didn't see your name up there. Great.
No, it was good. It was really good, actually, because it's one of the areas that's really evolved, I know, recently.
Yeah.
And, you don't really know what to do with some of these people.
And you know what? I think that's fair, Jenny. I mean, we've had statins for so long, and now we've got a bunch of new kids on the block, and we're all, I'm in this space every day, keeping up with it. So can only imagine how you try and juggle this in primary care. So, but no, look, please reach out, and the lipid clinic at the RA, we're trying to make more available to people, but the phone calls are always welcome. So, I hope you still got my mobile, but it's always there.
I haven't got your mobile, actually.
Oh, I've got your number, so I'll flick it to you.
Oh, have you? Oh, well.
I'm sure I do. If not, I'll send you an email.
Yeah. Okay. No, I don't send it to the Adelaide. I don't do Adelaide anymore.
Don't you? What are you up to these days?
No.
You just do consulting mainly.
Yeah, no, I opted out of Adelaide at the beginning of 2020. So I then went into GPEX and went back to GP education. And I was doing a lot of stuff with international medical graduates. But I've dropped a lot of that now. I do the 3 days of consulting, and and I do some of the stuff
with you out of trouble.
But things have changed, shall we say? So when they change,
yes,
yeah.
No, this is true. Well, I've not been around the uni much, so I wouldn't have missed you then, Jenny. But I put my number in the thread there, so please do reach out, and happy to receive any phone calls. All right.
Okie doke. All right.
Have a great. Thanks for saying hi.
That's good. Yeah, it's
all
really
right.
good.
Thank you,
See you
everyone.
then.
See you, team. Bye. Bye.